staircase for the beta-lactamases, starting with the penicillin and the penicillinase production, going to the more broad-spectrum penicillins and the development of the TEM and the SHV resistance, and going to the with the invention of the third generation cephalosporins, and then we had the extended spectrum beta-lactamases and the AMC. Using more carbapenems had ended up to the carbapenemases with the MBL, KPCs, and OXA48. So it's worth noting that not all beta-lactamases are created equally. And as you can see, that there are plasmid-encoded beta-lactamases found with gram-negative bacteremia. The different classes like class A, that includes the TM and SHV, the penicillin's first generation resistance, the cephalosporins, the extended spectrum beta-lactamases, and for the carbapenems is the KPC. For the class B, you can find that carbapenemases with the NDM being the most abundant. And for the class C, you can see the MC, and for the class D, you have the narrow spectrum OXA48, the extended spectrum beta-lactamases with D as the L-OXA, and the carbapenemases as the OXA48 as well. And these distinctions have treatment implications. When looking to the global burden of this disease, you can find that the KPC is the most abundant, followed by the OXA48. And looking into the region, for the Middle East and Africa, you can find the same. It's the KPC, followed by the OXA48 as well. Speaking about the economic burden of serious MDR, you know that the resistant or negative bacteria are associated with a high and a significant economic burden. Talking about low middle income countries, it costs more than 2.5 higher for the hospital costs compared with infections with sensitive gram-negative bacteria. And a couple of years ago, the WHO has updated the list for the priority pathogen list, with having priority 1 critical, the Acinetobacter baumannii, carbapenem resistant, the Pseudomonas aeruginosa, carbapenem resistant, the Enterobacterales carbapenem resistant, and the third generation cephalosporin resistant as well. And not only speaking about the ESBLs, NDRs, XDR, and the PDR, a new definition has just been entered, which is the difficult to treat resistant organisms, in the article by Kari and his friends and his colleagues, with these authors defined as any gram-negative bloodstream infection isolates demonstrating an intermediate or resistant phenotype to all first-line agents in the carbapenems, the beta-lactams, and the fluoroquinolone category. Looking on the impact of delayed appropriate antibiotic therapy, in this article by Kari and colleagues, you can find that 1 in 5 patients in the US received discordant empiric therapy, and receiving discordant therapy has increased the odds ratio of mortality, even in patients without septicemia. Looking at this as well, in this article as well, is the inappropriate empiric antibiotics treated in high-risk febrile neutropenic patients, in which they analyzed more than 1,600 episodes of bloodstream infections in neutropenic patients, and they found that a total of 24% had received inappropriate antibiotic therapy in the beginning. And in these, there were a high mortality, especially in the MDR, Pseudomonas aeruginosa. For the management guidelines, we now have the IDSA and as well as the ACME guidelines that have been published for the last couple of years, taking into consideration the availability of the old drugs and new drugs in each setting. So many questions should have been answered through this guidance, involving the novel the beta-lactam and the beta-lactam inhibitors to be used as empiric therapy, when and how, especially in the low versus the high settings. To decide the empiric therapy with the novel beta-lactam and the beta-lactam inhibitors, 3 main points should be taken in consideration. The local epidemiology, as we all know that not one size does not fit all anymore. The second thing is the severity of the illness, and finally the underlying disease. In this paper by Pontevers and Bassetti that has been published a couple of years ago, for the risk factors for developing infections with MDRs, you can find that the most striking were the previously known colonization receipt of broad-spectrum antibiotics and history of prolongation colonization. All are very likely to be present in our patients, but prior infection and colonization is the only specific risk factors in this paper. And hence, this takes us to the question of the rectal surveillance for CRE. What, how, and who? So, in the settings with high prevalence, having this CRE colonization status to guide the empiric treatment. Since it has been reported that infection rates vary between 7.6 up to 44% in different settings. Also, using the test that allow for mechanism-based prescribing to differentiate the KPCO support used in MBL, and actually in this state, not all the settings or not all the institutes have the ability to do this, to perform this genotypic testing. So it should be included in the infection prevention control and stewardship program in the institutes. And who actually, it depends on the local epidemiology and outbreaks, the high prevalence region versus the low prevalence one. So to take a decision for the empiric therapy, you have to look to take the patients from every aspect. The local epidemiology of your institution, the severity of illness, whether the patient is stable or not stable, the underlying disease, especially the status of the status of the immune suppression, and the prior risk of infection or colonization. All of this dictates the appropriate empiric antibiotic therapy, and this has been the guidance stated by the IDSA. So to have the empiric therapy appropriate to your institution, you have to look for the source of infection, the likely source. So treating a UTI is not the same as treating a pneumonia. Also looking for the susceptibility patterns of likely pathogens. The second thing is the severity of illness. The vital stable patient is not the same as the vitally unstable one. Taking into consideration as well the previous organism identified and culture susceptibilities. You do have the recent antibiotic exposures, since we do deal with immunosuppressed patients in high resistant settings, so we are using the carbapenems widely. Also, in addition to that, the patient-specific factors, the type of chemotherapy and the type of the immunosuppression you're dealing with. It has been debatable about the duration of therapy. Actually, for nowadays, the prolonged treatment courses are not necessarily used. This can be, as a general rule, used for gram-negative septicemias. However, dealing with MDRs is not the same case.